Hi, I'm Patrick Stiles, a registered massage therapist, and today I'm doing a quick little video to help therapists and students to become more proficient at treating psoas. Psoas is a muscle that lies in the abdomen and it often gets overlooked in treatment. I think partly because students and therapists are unfamiliar with the territory that they're working in and they're not very comfortable. So I've noticed a real need in the profession for more work to psoas and hip flexors in general. So I'm doing this video in hopes to help you be more proficient at that. So psoas major and minor combine with iliacus to form the iliopsoas muscle. Psoas minor is a relatively minor muscle which only is prevalent in 40% of the population. Psoas major comes from here, vertebral bodies of L1 to L4 and connects to the lesser trochanter on the femur. It's the only muscle that connects the spine to the leg, so to the femur actually, so therefore it is like a major hip flexor. So basically psoas comes down here, either side of the spine, connects right there. Iliacus is here in the iliac fossa, comes down, joins under the inguinal ligament, and comes right there. We have one each side. It's also referred to by a butcher as a filet mignon and a cow. It looks a lot like a pork tenderloin. It's a long, slender muscle that comes down there, and it's the main hip flexor of the hip. So we have here Netter's Human Anatomy Atlas. I'm gonna bring you to the posterior abdominal wall and the nerves that lie within this area. So what I wanna draw attention to is the genitofemoral nerve right there, which pierces through psoas. It comes from L1, L2, from the lumbar plexus, pierces through, and then also to the lateral cutaneous nerve, which is right here, which crosses obliquely over iliacus, and it would go underneath the inguinal ligament. These nerves, especially genitofemoral nerve, can get entrapped in a tight psoas muscle and cause groin pain and pain down the front of the thigh. So let's talk a little bit about indications for treating psoas. Anything to do with low back pain. A trigger point is a taut band in a muscle that refers pain somewhere else. So in psoas, the trigger point referral is along the low back and the upper thigh. Also, if a psoas is weak, short, tight, whatever, and it can't flex the hip very well, then rectus femoris, one of your quadricep muscles, has to work extra hard to flex the hip. So then you end up with a chronic quad strain. So in cases of groin injuries with the nerves that we spoke about, with low back pain, with thigh pain, with rectus femoris pain, any of those things we definitely want to treat psoas. And also poor posture. If someone has a really significant anterior tilt, likely means that their psoas is pretty tight as well. So there's a ton of reasons that we want to treat psoas. If someone's sitting a lot at work, running, walking, all those things, and we're doing a disservice by our clients by not addressing this muscle. So we're going to talk about what's on top of psoas here. We've talked about everything behind. So here we have rectus abdominis right there, serratus anterior, these sharp tooth muscles up there, and inguinal ligament is right here. And that's pretty much like the exterior surface, and obliques are right on there. Then behind there are the internal organs, which is why I think a lot of therapists are scared of treating this muscle. Let's talk about that. So we have basically, well, your diaphragm, which is another muscle, up underneath the ribs there and there, up underneath there. It descends down, which pushes the abdomen out when you breathe. We got liver up on this side, appendix way down there. We got your ascending colon, transverse colon, and descending colon. And those things will just move out of your way as you're going slowly into treating this muscle. Gallbladder is there underneath the liver. Other than that, I can't really think of anything we haven't covered, so I think we're ready to for the demonstration. So here's one option for draping, an anterior thigh drape. Flex the hip, and then you get into psoas like that. Option number 2 for a drape is an anterior thigh drape, an abdominal drape down to the ASIS, and a cover over the chest here. Flex the hip, get in there. So for the purposes of today, Elver's just wearing shorts, which is pretty common when you're treating an athlete at an event or sometimes even in clinic. You want to make sure they're comfortable and have a pillow under the head. You never want their head on the headrest when they're lying on their back. So first of all, when treating psoas, you want the hip to be flexed. You want that muscle to be as shortened passively as possible. So I'm going to get him to do a little crunch for me. Great, and relax. So right there I can feel the side of the abs. I don't need to look, I can just feel, and I know where the side of his abs are. Then I'm going to sink in a tiny, tiny, tiny bit, 45-degree angle underneath rectus abdominis towards the spine, and then lift your foot for me. Great. So what he did there is pretty common. A lot of people just dorsiflex. So if you're not feeling a contraction, psoas as a hip flexor has nothing to do with dorsiflexing the ankle. So I'm going to say actually lift your foot up off the table, whoa, and there's his psoas, like very prominent right there. So I'm not very deep. I want to go very slowly, and I want to test right away if I can feel where psoas is. Now that I know where it is, and the intestines have moved out of the way, I'm not worried about, being on anything else other than psoas. I know I'm on it. I just had him contract it. coming down into that muscle. Lift your foot again for me. Great, and relax. There, I had gone a little bit medial of it, so I just came right back on top of it. Once you're there, you're just gonna hang out. Again, more hip flexion is better. So you might make yourself comfortable like that. And then I can reinforce with my other hand, because sometimes therapists find psoas treating it is like hard on the fingers. So here I can reinforce. I can give a little bit of hip extension there, a little bit of hip traction as well. Then I can come under here as well, bring them into full hip flexion. I'm gonna extend that hip to neutral and get a little bit of long axis traction there as well. As my pressure is going superiorly, at this point I'm not going straight into the psoas, I'm drawing tension superiorly as I lengthen that femur up. One thing that a lot of therapists do is they're on psoas here. I'm gonna back off a little bit because I think this is very painful. So lift your leg up and then slowly lower it. So a lot of therapists do that with a really deep pressure on a psoas, and I find that's pretty painful and counterproductive. It would be the equivalent of asking Elvira to flex his bicep, hold like a 30-pound dumbbell, and dig in there as he's eccentrically lowering that weight. So that's something I wouldn't recommend. I'd recommend get in there and do everything completely passive to psoas for better results and more client comfort. Side lying is another great way to get into psoas because the abdominal contents will shift out of the way nicely and it's easy to get in there and very comfortable for the client. So just bend your hips a little bit more for me, Elvira. Again, because I want this muscle passively as shortened as possible to make it better for the client and easier on my fingers too. So I'm gonna feel where the side of rectus abdominis is, very easy to find. And then I'm gonna sink in a little tiny bit, 45-degree angle down towards the spine. Push your hand into your knee and relax. Good. So I was getting him to resist hip flexion there and could feel it pop out quite nicely or contract quite nicely. So I'm just gonna hang out there, okay? So my hands are nice and relaxed, super soft fingers. I'm trying not to be pokey whatsoever because that's not gonna feel good. Then I might add a little bit of dynamic movement. So I'm gonna put a pillow behind him. I'm gonna brace the hip there and then slowly bring that leg behind you. Yeah. And then reach back like that. Excellent. Now here my pressure is going superior. So I'm not going straight into the muscle belly, I'm going along the muscle fibers. I'm gonna ease the tension and then say come back to start. I'll demonstrate that one more time. So again, I know that I'm on psoas. If you're unclear, push your knee into your hand again, right there, and relax. And then go through that motion again, leg back first. And then arm back, like so, excellent. If you had another person, if you had a student with you or something, then you can actually get someone to bring that hip even into more extension and then bring that back. Good. So things to be cautious of or contraindications with working someone's psoas muscle. On the left side of the abdomen, you have your abdominal aorta. So if you're working in your psoas and you feel a strong pulse, just move laterally off it. Not the end of the world, but if it's beating at like 60, 70 beats a minute, then you don't want to hang out on there. On the right side, you have your appendix, which is pretty low. In a case of acute appendicitis, obviously that's a medical referral to the ER department or their doctor, but you just need to be cautious that the appendix is pretty low on the right side. There's the rebound test where if you come out of that area at the appendix, that's going to cause a lot of pain, which is immediate referral to the hospital basically. And then the other thing is common in athletes and a lot of people is inguinal hernias. So pretty low in here. You just need to differentiate in your assessment if it's a possible hip flexor strain involving psoas or if it's possibly an inguinal hernia. The ways you can do that is your intake questions. What causes pain? When does it hurt? You can activate the hip flexor. So hold that there, don't let me push you down. Does that cause a lot of pain in the hip flexor? Is it contractured? Is it really limiting their extension? Those are all the kind of questions that you want to ask. If you're in doubt, again, refer out to the medical doctor to rule out an inguinal hernia.